Hi there, and welcome to this podcast episode for Living Matters. I'm Nicky Thackray. I'm your host. I'm delighted that you're here today. And I've got with me Emily Lawson. Hello, Emily. Thanks so much for joining.
Hi, nice to meet you.
Thank you. And Emma Robinson as well.
Hi, nice to meet you.
Thank you. We're going to be talking today all about bowel cancer, okay? I don't know that much about bowel cancer, so I'm really ready to learn and lean in and listen to what these wonderful women have got to tell about it. So can I start with you, Emily? Can you just say a bit about what your role is?
Yeah, so I am the Health Improvement Practitioner for the North of Tyne Bowel Cancer Screening Programme.
Right.
A bit of a mouthful. I've only been in the role about 5 or 6 weeks now, but I've worked in the NHS for about 6-7 years. And my role is about trying to increase uptake, basically, across the whole of Newcastle, Northumberland and North Tyneside. So a lot of it is going out and doing like health promotion. So, trying to increase people's awareness of why screening is so important. And then another side of it is also like looking at the data, seeing like where the low uptake areas are, seeing what health inequalities are impacting people's uptake. So yeah, and it's about putting things in place to sort of reduce those inequalities and make it easier for people to do the kits.
Right. Okay. So you're trying to kind of raise the profile and raise awareness.
Yes. Get more people to do it because screening is really important. So.
Okay, brilliant. So I'll come back to you on that point. What about you, Emma? What's your role?
So I'm a Specialist Screening Practitioner. I'm actually the clinical lead, but a Specialist Screening Practitioner is a nurse. Our role is quite multifaceted. We are the main point of contact for the patient throughout their bowel screening pathway. So we do everything from assessing the patient when they come through and preparing them for a colonoscopy. We're there to consent them, support them. We're there to basically give lots of information so people can make informed choices about whether they want to participate. We manage the results pathway and MDT liaison, and we also support with a lot of health promotion as well. So it's quite a varied role.
So what's the MDT?
Sorry, multidisciplinary team side of things. So anyone that we need to refer to, we sort all of that out.
Right. Okay, brilliant. Thank you. Well, thank you so much for explaining what you do. This is helpful. So who should be getting screened?
Everyone from age 50 to 74 is eligible for bowel screening.
Right, okay.
If you're registered with a GP.
Yeah.
So every 2 years, you'll automatically receive an invitation through the post, regardless of what's happening anywhere in your life. Every 2 years, that invitation will pop through the post to participate.
And so what does the process look like?
So the hub sends out an invitation to the patients when they're eligible. And then after that, I think they get about 2 weeks in between that, and then they'll get a fit kit out in the post. Then they send back they'll fill out a fit kit, send it back. That'll go back to the hub, and the hub do all the testing. So the test to say, a fit kit basically looks to see if there's any blood in the poo, and it can find like tiny amounts. If the fit kit is positive, then they will get referred on to some of Emma and our SSPs, who will take them through an appointment where they'll discuss a colonoscopy, go through what that patient's like current health is like, whether it's suitable, whether they could have a colonoscopy or not. Then the SSP will sort of make the decision with the patient at the end of the appointment whether they can have one. If they can have one, they'll get referred on for a colonoscopy. If not, then they might look at doing something else, like is it CTC, something like that, or if it just wasn't suitable at all, referring them on to someone else. If they're coming for the colonoscopy, they'll have a colonoscopy.
The colonoscopy, that's the special video camera, is it? Yes. Yeah. So that gets inserted up.
Yes.
And then has a look around the bowel.
Checking for polyps. Yeah.
Right, okay.
So it's about a 45-minute procedure. There is a little bit of preparation that goes into that. You need to take laxatives so your bowel was emptied beforehand.
Yeah.
But yeah, it's a camera that goes on the end of a tube that goes into the bowel, right round the bowel. And we can have a really good look at the lining of the bowel then.
Right, okay. So just so I'm clear then, so it's from the ages of 50, that's when people start getting invited, kind of like as a routine check every couple of years. But what about pre-50? Like, what are some of the signs and symptoms that people should be on the lookout for?
Yeah, so things like bleeding from the bottom, any changes in the bowel habit that's not normal for them. So if you're going more often or less often to the toilet, if you're getting any pain, any lumps, bumps in your tummy, weight loss for no reason, if you're feeling tired all the time, feeling bloated, any pain at all. And it doesn't necessarily mean that you've got bowel cancer. They are very general signs sometimes, but any changes with your bowel habits, it's always worth going and having a conversation with your GP.
And so would they, if you went and had the conversation with the GP, would they typically give you one of these kits?
Yes, so they can also give kits as well, what we call the symptomatic pathway. Yeah. So if you go with symptoms, the GP will order the tests for you, but it's not within the bowel screening programme.
Right, okay. And so who are you tending to see? Because I've sort of seen that there's more and more younger people that are experiencing and going through bowel cancer. Is that what you're seeing? Like who typically?
So we've recently just reduced the age to 50.
Yeah.
So prior to about 5 years ago, we only screened 60 to 74.
Right.
And we've dropped the age now to 50. We see everyone on that age spectrum with bowel cancer, with polyps, but also people with normal tests or a bit of inflammation. Just because you've got a positive test, it doesn't mean that you've got a cancer there. I think in the news, there is a lot of people, there's stories about lots of younger people now with bowel cancer as well, coming through the services.
And so for the younger people, is it that they've tended to notice a symptom or a sign and then they've gone to the doctor and they've gone through the whole process?
That's exactly it. Yeah. They've had some bowel habit changes or bleeding.
Right.
And obviously at that age, you don't always expect those things, so it can be quite alarming. They've been to the GP who's then referred them on to other services.
Right, okay. So does it tend to be people who have a family history of bowel cancer? Like is that what the link is, or how is it caused? Do we know what's causing it?
Not really. There are some cases of genetic link.
Yeah.
And that's usually younger people. That's usually presents very young age. There is something called Lynch syndrome, who we screen as well. They can have an increased risk of bowel cancer. They think about 54% of bowel cancer cases are preventable, and that's through things like smoking, alcohol, lifestyle choices, not eating enough fibre, eating too much processed meats, all of those things. So it's looking at those things from a younger age. Changing our lifestyle habits, which is obviously easier said than done.
Yeah, but 54% preventable.
Yeah.
Wow.
So it's not all genetic. It's unlikely for majority of patients to have a genetic cause.
Right. And so if there are people listening and watching this and thinking, I had someone who was kind of in my family tree who had bowel cancer, like a parent or grandparent or something like that, is there anything different that they should be doing?
I think it's the same thing that everybody should be doing, really, is those things, is not smoking, modifying their alcohol intake, trying to exercise more,
do your fit kit when it comes through,
do your screening. Age is always going to be the biggest risk factor for cancer, majority of cancers. So if you've had someone that's 80 that's got a bowel cancer, then that's always going to be the biggest risk factor. If you've got parents that had bowel cancers in the 40s, 50s, 60s, definitely think about modifying that lifestyle.
Yeah, okay, thank you. And what about the sort of uptake and people doing the assessment, using that kit? Do you how do you encourage people to do it?
I think health promotion is a big part of it, and that's kind of why the team got me in, because we're trying to do it beforehand, but it's such like it's a full-time job for me now, so they were trying to fit it into the day-to-day of going to clinics, seeing patients, and it was just too difficult. So definitely health promotion, but I also think like education's a big thing as well, because even before I started in the team, I didn't realise that like screening was different to symptomatic cases. So just what we've been saying about how, if people have symptoms to go to the GP, I thought that was all the same as screening. It's not. Screening's really for like healthy people who have no symptoms. That's why we want more people to do the screening, because you may think, I don't have any of the symptoms that Emma's mentioned, but that doesn't mean that you don't have polyps or you don't have bowel cancer. You can still have it without having any symptoms. And I think bowel cancer it can radiate it's quite prevalent without symptoms. So yeah, I think education as well, and just making sure everybody knows it's so important to do these fit kits. That's what I'm going to keep saying, I think, over and over again today. But
do it. And And I guess there must be a lot of embarrassment, I'm guessing, for people when it comes to talking about like your bowels, like what's happening, what's changing. Is that what you find? And is that what puts a lot of people off?
I think like stigma and feeling embarrassed is definitely a big part of it. And I think it's cultural as well. Some different cultures, they don't want to talk about that, or it's a bit taboo. So like I do think that definitely plays a big part in it. But for me, like I just think everybody does it. When everybody goes to the toilet, like I think people talking about it more and things like this hopefully will normalise it and mean that people will feel a bit less, embarrassed to come forward. But at the end of the day, like it's a normal, like natural bodily function, just as it is like breathing. So it's nothing to be embarrassed about, I don't think. But I get why some people are. So I do think like having these conversations and when we're going around doing health promotion stands, just seeing us there with a big banner that says life-saving poo on it, like it does sort of, and it makes people like think, oh yeah. So yeah.
Yeah, because it is this sort of
bit of a dirty.
Well, yeah, it is,
isn't it? Yeah,
it is. It's It's, I can imagine. And is it fair to say, probably more so with the younger people, that they would be less willing to talk about it? Or
I don't think age plays a part in it.
Really?
Not from what I've found. I think you'll get, like, when I've been out and about speaking to, like, people and like patients in the public, there's some people that are early 50s that do it as soon as the kit comes in. They want to get involved, they want to make sure they're doing their screening, and then there's others that don't, and then you've got people that are in their 70s, oh, I've never done it before, why would I do that? I think it's, I don't think age really plays a part in it. I think there's like women are always more proactive about their health, so I think there's probably maybe a little bit of that, like that women are more likely to sort of fill the kit out.
And we see it when they come to clinic to speak to us. You get people that are really embarrassed and they're like, oh, this is a horrible thing to talk about, but we're obsessed by poo. We love it. We want to know. We want to know what.
Well, how did you both get into poo in the in the first place? It's a good question. Like, how did you end up doing this job?
I think I fell into it, really. I've been a nurse for almost 20 years, and majority of my career I've fallen into jobs.
Right.
I had enough of the ward work. I was burnt out. I looked for something else, and I actually went to endoscopy. So that's how I first became aware of like bowel cancer screening.
Right.
I got seconded into the bowel screening team, and I loved it. I was fascinated. I'm fascinated by colonoscopies. I'm fascinated by the bowel, and I've worked my way up from a band 5 to now the band 7. I love it.
What do you love about it?
I think it's at making a difference. I think, yes, we do find bowel cancers, and we don't set out to find bowel cancer. We set out to prevent them. Mm-hmm. But actually, majority of our patients, we find cancer early, at the earliest stage when they don't have any signs or symptoms. Right. So actually it's nice to follow them through the journey and see that they have a really good result from that.
Yes.
And that, we attend meetings and we hear that the surgery's gone really well, because it's found at an earlier stage as well, and not an emergency presentation. They're really well prepared for their surgery. Mm-hmm. They have really good outcomes. They're living longer. Mm-hmm. So yes, it's not nice finding bowel cancers, but actually it's quite satisfying knowing that we've prevented a lot of bowel cancers.
Yeah, I can see that.
And that the bowel cancers that we do find are generally early, and yeah.
So what's the message normally? Like you were saying before, that often you'll tell the person, like maybe on the same day when they've had the colonoscopy. So how do you give that message to someone, which is, yes, we've found some bowel cancer, but we believe that it's early stages and it's going to be treatable?
So we never tell them what stage it's at. It's a part of the job that's really hard, but it's a part of the job I quite love as well.
Right.
It's really hard to break bad news to someone. And we usually try and do it with a relative present. Like we'll take them into a quiet room. I think it's trying to rip that plaster off. Mm-hmm. There's no easy way to tell someone that they've probably got cancer. It's giving them that space to kind of absorb that information without rushing them, without trying to fill all that space with talk, just giving them that silence to try and process. I think then it's about just then giving them information about what the next stages are, about the fact that they'll have some scans organised for them, that they'll be handed over to the colorectal team, who are absolutely amazing, do an amazing job themselves. But just guiding them through what that next part of the process looks like for them. At that point, we can't ever tell them what the stage of the cancer is until we've got scan results and we've had a look at the full picture.
Right, okay.
So it's really hard for the patient because they're kind of in limbo until all of that's back. So it's a really, really hard couple of weeks for them, waiting around to have the scans and then get the results back and find out what stage they're at, what's the next part of their process. I think I was always told when discussing bad news that if you do it badly, they'll remember that as a trauma for the rest of their lives. But if you do it well, they might never remember your name, then they might never remember what you've said to them. Actually, I think that's a really important job for us to do it right.
Yeah, and I can tell actually, I don't know you very well at all, but I can tell that the approach that you must take, it must feel gentle and really compassionate and caring, and you're not in a rush.
No, it's their time. It's their time to process. It's hard because you never know what people's reactions are going to be. You get anger, you'll get crying, you'll just get complete shutdown silence. Regardless of what's happened on the day, we always ring our patients the next day anyway. So when they've had that 24 hours to kind of process things a bit more, we always ring them up. And if they've got questions, that's what we're here for. That's part of our role, is to provide them information, to make sure they know what's happening, to make sure that there's no confusion.
Yeah. And what about the anger? That's interesting that sometimes the initial response is anger.
Yeah, it's a hard one. Sometimes it's aimed at us. Sometimes it's just general anger that they've got a cancer, that some people have lived really healthy lives the whole life, and they've still got a cancer there. So they can be quite angry at that news, angry at the universe, angry at me or us because we're giving them that news.
The famous messenger.
Yeah. It is hard. I think for me, the hardest part is when you get the silence and the shutdown. It's really hard to read what's going on behind those eyes.
How do you tend to handle that in the moment?
I think just giving them some time, knowing that it's all right to have a bit of silence in the room so that they can think about things and process. I think making sure that they've got someone to go home to. If they haven't got a relative there, seeing if they've got someone to go home to, someone to talk to when they're ready to talk. But also knowing that we'll be calling them the next day to check in on them, check that they're all right, but
check that they're processing.
Yeah. It is really hard. It is hard. And I think they're the patients that I come away and sometimes have a little cry after they've left. Have a little cry and then put your mask back on and next patient.
Yeah. You must have to be really sort of resilient and able to do that resetting of yourself multiple times, I guess, throughout the day.
It's a skill, and I think it's not always easy. You learn it when you're a nurse. You're in positions all the time as a nurse. I think I work with an absolutely amazing team. I've got a fabulous team that work alongside me. And there's often that we'll come back to the office and we'll talk about patients that have upset us, and even just us talking about it with our colleagues, or saying that we're upset, or saying that we've had someone that's really angry and it's upset us, or those things, we do reflect on them. We're very supportive as a team, and there are days we come back and say, that was a really tough one. But it really helps for us to talk about it amongst ourselves.
Of course, yeah.
And you still take it home sometimes, but it's the nature of the job.
Yeah. So let's just say they've had the colonoscopy, they're getting the news from you, and then you said the next step is that they'll probably get scans in a couple of weeks. Have I picked that up right?
Yeah. Very quickly. because they're on a cancer pathway, we want to get it treated as soon as possible.
Yeah.
We want to know where they're at, what we can do, like boom, boom, boom. So yeah, it'll all happen very, very quickly in our terms. But when you're sitting there with that diagnosis, it will still feel like a massive age for them.
Yes, I'm sure. And what is the treatment typically?
Oh, that's a hard question to answer. I think it depends whereabouts the bowel cancer is. Depends what stage it is. If it's a very early stage, ideally surgery, chop it out, put you back together. Sounds very simple. It's obviously not.
And how does that work? Like chopping it out of the bowel?
It would require removing part of the bowel.
Right.
You'd be seen in clinic beforehand by one of the colorectal surgeons who, again, do fabulous work, absolutely fabulous work. They would go through the operation, whereabouts in the bowel it is, what it would involve, what the patient can do beforehand, leading up to the surgery. There's something called prehab now, so that's a prehabilitation. So that's kind of preparing your body for surgery, kind of physically and mentally. So making sure you're cutting down on your smoking and your drinking, trying to get some exercise in for recovering, because it's not easy on the body having surgery. But yeah, they would remove part of the bowel and surrounding nodes along with that, and then stitch or staple your bowel back together. It's a beautiful piece of art, really.
It sounds it. And then typically, do people recover well after that?
So that's kind of the message for screening, is that if you're coming through the screening program, generally we find the cancers at a much, much earlier stage.
Right.
That they're prepared for the surgery because they've had time to process. They've had time to do a little bit of exercise before the surgery. They know what's going to happen in the surgery. And they're prepared mentally for it as well. So that when they do have that surgery, they have much better outcomes mentally, psychologically. They come through the surgery much better. They go home, they recover quicker. They're surviving for much longer. People that present with like a later stage bowel cancer, it's usually kind of found as an emergency presentation, or because they've got signs and symptoms, they're not always prepared for that kind of diagnosis. If it's at a later stage as well, it might that they require emergency surgery, so they don't have time to prepare for that. It's kind of quite a rush. Let's get you in. Let's get this out and sort you out. It might be that the cancer's spread on a later stage as well, and surgery might not be an option, might not be suitable. Early stage cancer, bowel cancer, is very, very treatable. Late stage cancer is not so treatable. So I think it goes to 90% of people with an early bowel cancer go on to be cured, have 5-year survival rate. It's only 10% of those with a later stage of bowel cancer, and that's why it's really, really important to get it diagnosed as early as you can.
Yeah. Well, thank you for that. And what about you? What do you love about your job?
I think just like the variety of people that I work with, that I'm meeting now. In my last role, I sort of did similar work to do with health inequalities, but it wasn't as like patient focused, and it wasn't like patient facing really. Whereas I know I don't see patients every day like in my mind, but I definitely see them more. And I think they're similar to what you said. They're just being able to know that you're making a difference, and yeah, I like that. I've missed sort of working with patients, so yeah, I enjoy that.
Brilliant. If you've got someone who has received the diagnosis, is there any specific, or are there any specific bowel cancer communities that they could be part of and find out more information and support?
So on a local level, I couldn't really find any like bowel cancer support groups. I'm sure there is them out there, but I couldn't find them. But on a national level, there's Bowel Cancer UK, which is really good. It has loads of information, like loads of resources. It tells you more about the bowel, about like the different treatment options. It's just got everything, hasn't it, really, to do with bowel cancer.
So that's like the place to go for more information.
Anything you want, yeah. And yeah, there's loads of resources on there as well that people can read up on as well. But if a patient did get diagnosed, you obviously, as you mentioned, the colorectal nurses are there, and they're really, really good, and they would be able to refer the patient on or signpost them to sort of any like local groups. Yeah.
Okay. And I think because this is where the charity like Sarah's Star would come in as well and be really useful to people, because Sarah's Star is all around helping people who are facing incurable illnesses. And so it is people with bowel cancer or breast cancer or any, like all of these different types of incurable illnesses. And I think one of the things that people love so much about being part of the community is that even though I think they feel like it's quite daunting, where you're kind of going to go along and you don't know anybody yet, but it's such a warm and welcoming place. And there's so much support, and there's just so much, like sort of friendship available in that sort of space. So for anybody, if you are interested and if you are facing incurable illness, or someone who is, then look into charities like Sarah's Star, and look at what are some of the opportunities and the events and things like that are on, because there's all sorts. I mean, say for Sarah's Star, there's the Death Cafe, there's Reiki sessions, there's the book club, which is like the most popular book club I've ever seen. There's just so many different options for people to start to get involved, and people always say that that they come along and they just within a few minutes feel really relaxed.
I think it's really nice to have that support from people that are going through the same thing as well, but a network there, because not everyone's journey is the same. Not everyone has great family, like massive family to rely on, and sometimes it's nice to have people outside of the family where you can just go and talk about things, but not just talk about cancer. Talk about stuff, focus on something else as well. Like, I'm sure it's there if you want to talk about it, but actually go and take part in these activities and get out, step out of that zone for a little while. And I'm sure you must see people that some days are doing fantastic, and then you see them a couple of days later or a week later and they're having a really bad day, and
that's it.
I suppose everyone's in that same boat, and everyone has that understanding, I suppose, don't they?
Yeah. And I think one of the things that's been really interesting for me when I'm meeting people who are coming and using the services at Sarah's Star is that they'll say, like, I've got a lot of people who say I've got close family and I've got close friends, but I don't always want to talk about how I really feel with them because I don't want to upset them, and so actually being able to be kind of in a room with other people who really are probably feeling very similar at different times, and you're not risking upsetting them because they're not the people who are kind of, the closest to you in your life. It's such a valuable thing.
Yeah, I think so. I agree. Definitely, yeah.
So how big of a problem is bowel cancer? Have you got any kind of like stats or information?
So it's actually the fourth most common cancer in the UK.
Is it?
Yes.
Wow.
More common in men as well. So about 1 in 17 men will experience it and they'll have it in their lifetime, be diagnosed. And 1 in 20 women. So it's not much different, but there is a little difference. So if you think about it like that, that's probably either you or someone at least, like when you think about numbers that small. So it affects a lot of people. And I think around 48,000 people are diagnosed every year with it. Obviously different stages and things like that. But yeah, so it's a big problem. That's why screening's so important, isn't it? Getting it, finding it early, and, when it's easier to treat. And
yes. Yeah.
It's really important.
Oh, that's good to know. 48,000. Gosh.
Yeah, it's a lot.
It is a lot. It is a lot. And so 1 in 17 men, did you say?
And 1 in 20 women. Yeah.
At some point.
In their lifetime will be diagnosed, yeah.
Wow. So what's the conversation then that you both wish people were having more? Is there a conversation you wish people would be having more?
Have you done your fit kiss?
Yeah. I think just talking a bit more, normalising bowel health. Yeah. And trying to reduce that stigma around it. I think, it's treating it like any other bodily system, like your cardiovascular system. It's your bowel. You put something in, something has to come out.
Yes.
And if there are changes, like talk about it with people. It's poo.
Yeah.
It's, we all do it.
Mm-hmm.
Yeah, I think that normalising the conversation, have the conversations with children so they're not being brought up with that taboo.
Yeah.
Start having these conversations early.
Yeah.
Yeah.
Not being embarrassed. It's a normal, everyday function, or hopefully everyday function.
Well, so that's a good question, actually. So how often should we be going?
Oh,
Everybody is different on the...
Yeah. We see people in clinic that might go once every 2 weeks. We'll see some people in clinic that go 3 or 4 times a day. It's what's normal for you.
Yeah.
Right. Okay.
Obviously, if you're having a nice high fibre diet, which you should be doing, it should bulk your stools up nice. You should be going a bit more regularly, relieving that constipation and diarrhea, depending on which way you are.
Mm-hmm.
I think the important thing is noticing what's different for you.
Yeah.
So everybody's got a different normal. Is when your normal starts to change.
Yes.
Is when you need to start thinking, actually, not comparing yourself to somebody else's normal.
Yeah.
We're all different.
Mhm.
Everyone that comes into clinic has a different pattern.
Yes. Well, it reminds me, actually, there's a friend I had years ago, and she would go once every 2 or 3 weeks. And I couldn't, but she was like that. She was just like stick thin, and she would eat normally.
Mm.
And I couldn't understand where it was going because it's not coming out anywhere. But so what would have been going on?
I have no idea. People that only go once every couple of weeks still befuddle me. If I go longer than half a day, I feel constipated.
Yeah, sorry, and bloated. This it. We need to normalise the conversation.
It's true. Once every 3 weeks.
Yeah, people that go that very little.
Yeah.
I can't get my head around.
I can't
Still
get my head
after
around it.
almost 20 years.
She was. Her body was like that. It was just one little stick,
God knows.
And she was living in Italy as well, so she was having pizzas and pastas and everything, and my head was scrambled just thinking, where on earth is all of this food going? It's not coming out where it's meant to be going out.
Yeah, that's the wonder of the human body.
But if there are people sort of watching and listening and thinking, well, yes, I'm one of those, like 2 to 3 weeks, it's not necessarily something to worry about, is it? If that's how it's always been for you, the problem is if that
starts to change.
Yes.
If you suddenly start having diarrhea, or you're going every day all of a sudden, or you're seeing that blood in your stool, you're having any pain, then have those conversations with your GP, talk about it. Like I say, everyone's different.
Yeah,
we're all made differently. Everyone's bowel works differently.
Yeah. But if we want to have the healthiest possible bowels, there's a few things that you've said already, which is like not smoking.
Yeah.
Limit alcohol.
Yeah.
What else? What about water?
Yeah.
Staying hydrated.
Staying hydrated.
Yeah.
Fluid intake.
Mm-hmm.
I mean, it doesn't have to be water, but keeping your fluids up with non-alcoholic, not necessarily caffeinated drinks.
I was going to say, what about caffeine? Because
we're all quite guilty of that, aren't we? But ideally water, but it doesn't have to be water. Flavoured water, flavoured teas, juices, sugar-free juices, those kind of things all help. It all counts towards your hydration.
Yes.
Fibre.
I was going to say, what would you recommend? Like, what's the best?
Green veg and brown bread, that sort of thing. Like green leafy veg.
Yeah, green vegetables,
right?
Beans.
Yeah.
Beans are an amazing source of fibre.
So what, as in like kidney beans and chickpeas and butter beans and all that sort of
all
thing?
your legumes, whole grains, all of those kind of things. Perfect.
But you've got to drink more, haven't you, when you take more fibre, and you've got to increase your just to balance it out, sort of, haven't you?
Yeah.
Way more fibre. It's important to
build up gradually with fibre. If you are planning on increasing, build up gradually, because you can get very constipated.
Mm-hmm.
Yes.
If you suddenly go from having this much fibre to that much fibre.
Yes.
you can get very constipated.
So nice and gradual.
Nice and gradual. Let your body
Get used to it.
just because you probably will be a bit bloaty, a bit farty
Right.
when you start increasing your fibre as well, because your body's getting used to it. It's having something and it's like, what? Used to this going on here.
Yeah.
And it's just producing all those natural chemical reactions. But if you stick with it, it does settle down
Right.
eventually.
And if you've got someone who is quite constipated, what's the best thing they could do?
Lots of fibre. Make sure they're drinking plenty.
Right.
Make sure that you're having 8 to 10 glasses of water or fluids a day.
Mm-hmm.
It might be normal for you, but if it is uncomfortable, speak to your GP, speak to a pharmacist.
Mm-hmm.
There are things that you can take, over-the-counter medications, to kind of ease that off a little bit if it is uncomfortable, if it is painful.
Yeah.
Some people are on medications that make you a bit constipated, and sometimes you just need a little something to give you a boost there. But
Yeah. So other than, because I know one of your big messages, both of you, is to use your kit. Other than that, what's your big message for people?
I would probably say, obviously, fill your fit kit out, but if you get symptoms in between your fit kit, don't wait for your next fit kit. Go to your GP.
Right.
I know you might think there's something like that too, but just don't wait. Just go to your GP and tell them about the symptoms you've been having. That's what I would say.
Right.
yeah, I'd say look at your poo.
Yeah.
People flush, but don't look down the toilet to see what's there.
Yeah.
Have a look at it. See what's normal for you. Get used to it. And again, if you do notice any changes, have those conversations earlier rather than later.
Mm-hmm.
Don't be embarrassed. Make it normal.
You can't really notice changes if you don't know what normal is to you as well. So yeah, definitely look at your poo. That's a big one.
Yes. How lovely.
Yeah. This is dinner conversation services.
Brilliant. Is there anything else that you would love to talk about? Is there anything else?
I think for me, it's taking part in screening. It can be a bit scary. But it's not about finding cancer, it's about preventing cancer.
Mm-hmm.
So cancer forms from polyps, which are fleshy growths in the bowel. And as they grow, they turn into cancer. So if we can take them off when we see them, we're really preventing you from getting cancer later on down the stage. So even before you get to that early cancer, we can be taking these precancerous polyps away and hopefully stopping you from progressing to bowel cancer later on in life. It's scary. So people that do fill the fit kit in and come to clinic, like get an abnormal reading and come to clinic, it is really scary. And I think my dad's been through the process before I joined screening, actually. He was quite blasé about it. He's like, I can't change it. It is what it is. I'll go along. My mother, on the other hand, was planning his funeral. She'd cancelled all the holidays.
Oh, wow.
So it can be quite scary. And we, as nurses, we understand that. We understand it can be really anxious time. And we're not saying a colonoscopy is the most pleasant procedure in the world, but it's not. It's a necessary thing, really. It's not as bad as people think.
Is it painful?
It can be uncomfortable.
Uncomfortable rather than painful.
Yeah.
Right.
Majority of people say that the laxative drink that you have leading up to the colonoscopy to clear your bowel is probably the worst part of the test. It's not pleasant. You'll get a lot of horrific diarrhea because we need your bowel nice and empty and clean.
Yes.
The test can be uncomfortable. I think if you've had a lot of abdominal surgery, can make it a bit more uncomfortable. In general, most people say, I don't know what I was worried about.
Right. There is a thing that there's a friend of mine, she has breast cancer and she talks a lot about scanxiety, as in scan anxiety. Can't even get the word out. Scanxiety. There you go. Yeah. And I think I can completely understand how overwhelming and how sort of, panicky you probably would feel because you haven't got control and you don't know what you're about to be told. What's your advice for people who are feeling really nervous ahead of scans and having the scanxiety?
Do you know what? I think it's okay. I think people tell you not to worry, but it's okay to be a bit worried. It's normal to feel anxious. It's normal to kind of think, what if, what's going to happen? It's that unknown. And I think that's absolutely normal to feel a bit anxious. I think if you don't do anything about it, if you don't go for your scans, you don't go for your test, that anxiety will just build. So I do say, come for the procedure, go for your scans, because it'll give you some sort of peace of mind or closure of some description.
Yeah. I also think people hear, because obviously it's bowel cancer screening, so when they hear, I've got a positive, test kit, I need to come in, they just assume, don't straight away, since it's bowel cancer screening, I have bowel cancer, but it could be, the blood in the poo could be off not off a million things, but could be off so many different things. It doesn't necessarily mean that just because you're coming in for a colonoscopy that you have cancer. So,
so is that what a positive result would be? If there's some blood in the poo?
That could be caused of anything, like hemorrhoids, or even if you just had like a tear. There's so many things that can cause it. So it doesn't necessarily mean that it could be that you've got polyps and that, and there's blood bleeding and that which then can go into cancer, but it doesn't necessarily mean that you do have cancer. I think that's quite important. So as I say, I think people hear bowel cancer screening and it's like, when they hear they've got a positive result, but it doesn't necessarily mean that you have bowel cancer.
Right. I think only about 10 or 11% of people that go on to have a colonoscopy do have a cancer.
Right.
So 90% of people don't have cancer.
Right.
Yeah. About 50% have polyps that we can take off.
Yeah.
Would you do that there and then?
We do.
Yeah. During the colonoscopy.
During the colonoscopy, if it's safe to do so.
It's very good. I got to go and watch them when I first started. From not being in a clinical perspective, it's very interesting. But they just get them off straight there and then.
How do you do that?
So the scope that we use, that's got the camera on, it's got channels going down there. We feed snare down there.
What's that?
So it's a bit like a cheese wire.
Right.
We feed that down. It's like a lasso type.
Yeah.
Put that over the polyp. We pull it, and the polyp comes off. And then it's like suck it out, don't you?
Yeah. And then you suck it out.
Yeah. So we retrieve them and we send them off. Ones that are above a certain size, we send them off to the lab to be tested.
Right.
And we can do all of that on the day.
It's very interesting.
Wow.
It blew my mind when I saw it.
It's absolutely fascinating watching a colon.
It is.
So you basically pull the polyp off with a cheese wire.
Yes.
Right.
You don't feel
and then vacuum. But if the polyp though, because whatever the polyp was attached to, does that not then got the same cells?
No.
Right.
We take off a bit of the bowel tissue as well at the same time.
Oh right. Okay.
So we'll try and get all of that polyp off.
Yes.
Yeah.
It doesn't always happen. So sometimes we do need to bring people back for more tests.
Yeah.
Or if they've got a lot of polyps or a really big complex polyp, we might need to bring them back for another procedure. Obviously we want to keep the patient safe. We do only have a limited time slot as well. So it's about doing what's right for the patient.
Yeah.
But majority of our patients will come in, take those polyps up on the day, off they go.
Right. Very efficient. Very efficient.
Right.
That's amazing. Well, I feel really well educated now. Thank you. So I started off knowing absolutely nothing about bowel cancer, but what I do know now is there's 48,000 cases in the UK per year. I understand the stats for men and women. I understand that the earlier you detect it, it's much easier to treat it. And understand about the colonoscopy and what happens in there. And I have to say as well, the amount of care that you show that really comes across from both of you. I think that must make all the difference to the people that you're dealing with.
I think everyone in our team loves the job that they do.
Yeah.
We don't always get it right. We're not a perfect service, but every single person in that team sets out to do a really good job for the patient.
Yeah.
It's all of the patient is first.
Definitely. Yeah.
They are centre of our world, basically.
Yeah. I bet you get nice cards and letters. Are you one of those teams?
We get some.
Yeah.
How did you? Yeah. We do get some. Yeah. That's lovely.
Yeah. Well, thank you for the work that you do, and thank you for coming to talk to us about it. Any parting messages that you have for our listeners?
Do your fit kit.
Do it.
Do it. And even if you have a positive test, it doesn't mean you've got a cancer.
Yeah.
Come and see us.
Yes.
Come and have a party in clinic with us. We'll guide you through everything.
Well, thank you so much, both of you. And thank you so much as well for listening. If you've got any questions, please do put them in the comments. And I'm sure both Emily and Emma would love to answer any questions that you've got. I would love to if you've got a question for me too. But I hope you feel better informed about bowel cancer. So whether you're someone who is experiencing bowel cancer or, supporting someone else who is, hopefully this has given you a bit more information and we understand where we can get more resources and support. So thank you, and we'll see you next time. Thanks.